right, let me make sure I'm recording. All right, and we're live. Dr. Rose, how are you doing?
I'm great. How are you, Cole?
I'm doing great too. All right, so quick introductions here. My name is Cole Cipher. I'm one of the co-founders of MedMatrix, and I'm joined here by the brilliant Dr. Rose. Dr. Rose, why don't you kind of give those who don't know you, who live under a rock, kind of your background and all that.
Yeah, my name is Dr. Sasha Rose. I am a naturopathic doctor. I'm a licensed acupuncturist. I sit on the Forbes Health Advisory Board. I'm a published author, and I'm one of the lead providers here at MedMatrix.
Fantastic. Couldn't have said it better. So what are we going to be talking about today?
We are talking about this sounds like a big topic, but taking control of your health. Really kind of diving a little bit into the health insurance model, how kind of health insurance has shaped the conventional care model that we all kind of live with, and kind of contrasting that with a more preventive approach to healthcare.
Yeah, perfect. So like, when did you start to realize that like kind of insurance plays a big role in like the healthcare people receive? Because has it always been that way? Like, can you give me some context here, reviewers context?
Yeah, and I don't know if we need to say it because it's not as such a medical topic, but I think we probably should always say that, anything that is discussed health-wise is is educational only, and we're not giving any medical advice today. I don't know that that's super applicable to today's topic, but well, I feel like pretty early on, I've been practicing for 20 years. I've been practicing functional medicine for 20 years, and I think it's always been a little bit of a struggle of wanting to kind of provide access, let people kind of use their insurance when they can, when possible. But the struggle is that the kind of medicine that I love and that I'm passionate about doesn't necessarily fit within that model. So I think pretty early on in my practice, just kind of trying to find the balance with that. And I guess I would have to say, like, both working within and not within the system. Mm-hmm. So it's been a while.
Gotcha. When, again, kind of just like higher level stuff here, when does it make sense to work with insurance, and when does insurance kind of almost work against you?
Well, that's a difficult question. When does it make sense to use your insurance versus not using your insurance? I mean, when it's something kind of straightforward, if there's a medication that you need and that you have a prescription benefit as part of your insurance plan, use your insurance. Don't pay out of pocket. I think we might dive into this later on, but conventional medicine does have some preventive screening tests that are kind of built in, like a mammogram, a colonoscopy. There are some tests that are intended, they're preventive. And if you're at a certain age, if you're a certain sex, then your insurance will cover that. Use your insurance for those things. I do, like at MedMatrix, we do not practice primary care. That's not our role. And I really do want my patients to have a primary care doctor. I want them to have, because there is a way that those offices, when they're working well, can serve my patients. And people will, usually be using their insurance when they go see their primary care doctor for various things. So I guess I would say when it's straightforward and also emergency care, use your insurance. You know what I mean? Obviously, I think it's obvious. If you're in an accident or you need to go to the emergency room, that's a great time to have insurance. If you are looking for deeper root cause aspects of your care, if you want a deeper level of preventive medicine, it is often extremely frustrating to try to use your insurance and stay within the model to get those answers, to get the comprehensive tests, to get kind of a visit that's longer than 7 minutes, to get a real in-depth, comprehensive look at your health. That is often, just a lesson of frustration.
Okay, so why is that? I think that's why people are curious.
It's not. So one piece of it is that there's this term like fee for service model, which is really what our current healthcare system is. And that is that the hospital, the provider, the lab, they get paid on like a procedure, right? Or a 10-minute visit, a 15-minute visit. That's how they get paid. And so every, unit of service time is paid for. Every it's very kind of itemized, and that's how a hospital or a clinic will get paid. They're not getting reimbursed on like patient outcomes, right? Like it doesn't really matter how healthy a person is. They're not reimbursed with positive outcomes or healthier patients. It's just so like it's all based on productivity. And that's why the short visits, that's why providers are really kind of forced to see as many people in a day. And that's why everything is just kind of like not personalized. And because that's how insurance is, that's how anybody's going to make money, is by those procedures and those quick visits. What was your original question?
Well, I guess like maybe let me ask a different way. Is like I guess I asked like first we asked like what is insurance good for, and then what is insurance not good for?
Yeah.
And then we kind of asked like why is that? So you explained that like it's really not great for preventative health outcomes because it's more itemized. So I guess like why, from your clinical experience talking to a lot of patients, like why are so many patients like frustrated with the insurance model? And like why is what you just described like not the best system for patient outcomes?
There's a lot of reasons why the current kind of insurance-based model is not the best for patient outcomes. It's really focused largely on disease management. It's not looking at true preventive care. And so people are frustrated when first of all, at least in Maine and New Hampshire right now, there's a huge lack of primary care providers. And so people aren't even able to get a primary care doctor. If they have one, that individual and that primary care office is like spread really thin. So access is really limited, right? People have a hard time even keeping a doctor. People no longer have a relationship with their primary care doctor. And when they do see their doctor, it's really short. And there's a high level of burnout among primary care doctors. And it's not their fault. It's the system. And people are not getting kind of really adequate attention or care. And it's it's not personalized in any way. And people are just feeling frustrated. And I think in a good way, we have access now to social media, and we have access to kind of a world outside of our little town or our city. And people are finding things like functional medicine. They're realizing that there maybe is an alternative.
Right.
People are going to their providers and they're asking for more in-depth testing. And unless they have a very specific diagnosis already, the insurance will not cover testing. And or the provider feels like it's not warranted, and so they won't order it. And so people get frustrated with that, and people come in and they feel really tired, they feel exhausted, they're not sleeping, and they're either dismissed or they run one test and they say, well, your thyroid is normal, and so you're fine. They're put on an antidepressant. Like people feel very dismissed.
Mhm.
That's I mean, again, I don't blame individual providers. I just feel like it's mostly the system.
Gotcha. So, like, in your opinion, like, what's like, well, I guess we'll get into, sorry, we'll get into that later as far as like how can you take advantage of it, and like what's the best use of functional medicine versus insurance typical medicine. But I guess let's kind of stay on this topic a little bit. Why, like, what's the relationship between, because you talked about like the short visits, like I feel like that's pretty logical. Like if you have 7 minutes with a patient, health is pretty complex as is. So like 7 minutes, pretty common sense, not enough time to actually do anything. But where does insurance start to play a role in like the actual treatment side of things, right? Because it's also restricts patients that way as well. Can you kind of explain that when it comes to actually like, okay, now that you have a disease or you want to be preventative, like what's the problem with insurance there?
Right, because insurance will only pay for certain medications. There's certain medications that are much more expensive than other ones. Mm-hmm. So to answer your question of, how does insurance come into play with treatment? I mean, a lot of people are on certain medications because that is the only one that their insurance will cover. Like there might be other potentially better options for them, but if their insurance doesn't cover it, it's not possible for them. And so literally like their care is being shaped by their specific insurance plan. And that, as we know, of course, insurance companies want to save money. So that patient, the only medication available to that patient potentially is the cheapest one. And it takes a lot of work, documentation on the part of the prescriber to try to get an authorization on a different medication. And if that patient doesn't check all the boxes in terms of specific diagnoses or test lab results, then their insurance will deny that medication. And sometimes that's true even with imaging, right? Like if somebody, needs an MRI or a CAT scan or something, unless they meet very specific criteria, the insurance will deny paying for it. And so I don't even think we realize kind of in general, the general public realizes how kind of deep the insurance clause are into our healthcare and how it's really does really shape so much of the care or the lack of care that we get. Mm-hmm. And in addition, like things that that are like pretty big in our toolbox in terms of really high quality nutraceutical supplements, botanical medicine, even like certain aspects of like lifestyle medicine, right? Like recommending that somebody go to the gym regularly or, access something that's beneficial for their health in terms of exercise or nutrition. None of that is insurance reimbursable, right? And so that's just like no one's going to get reimbursed for taking some really safe, high quality nutraceutical products. And they can, for some people, they can be expensive compared to, I don't know, some pharmaceutical that's really kind of cheap.
Mm-hmm. Yeah. And I guess why, like, I have in my show notes here, it's like insurance really focuses on kind of like the symptoms and with disease, like not actually treating the root cause. Can you explain? That's really what functional medicine focuses on, right? So like, what's the difference between like root cause medicine with like, that you'll see in more cash pay practices versus like conventional insurance medicine?
Right. So kind of chronic conventional medicine is the goal or the intention. It is really about managing chronic disease. And so that's, when, for example, when we're going over blood work with somebody, it's like somebody with certain diagnoses, like they're just going to have a certain limited amount of blood work. And if they are, technically their results come back within, normal, mm-hmm. Then they're going to basically stay on the same medication. If they're not quite within the normal, then their medication is going to be adjusted. And then maybe they're having side effects from that medication. And so they're given a second medication to manage the side effects. And it's really literally just managing a disease. And, we talk a lot about, it's really kind of the lifespan. Like it's really about managing a disease so that an individual can stay alive longer. There is no intention about for health span. How well is that person going to live? It's not about that. It's not about mental health, overall physical health, mobility, metabolic health, hormonal health. Like that's just not part of the picture. It's really like managing a disease so that somebody can literally stay alive. And as opposed to what we practice, which is root cause medicine, and that is we have the ability of spending more time with people. We're not limited by insurance. And we have a large toolbox that sometimes includes medications. It sometimes includes natural therapies. It often includes hormone optimization. It might include peptides or other like regenerative medicine, and a lot of lifestyle medicine. So a lot of looking at like what food, what nutrition is ideal for this specific person. It's not one diet for every person. It's very customized. Same with exercise. Not everybody's meant to, be a runner and run 3 miles a day. Other people, Pilates or yoga, that's what's best for them. And so we're really personalizing it and working with people and supporting people in a way that's kind of getting to, well, why? And we have so many like advanced tests, that available to us that help us dig deeper and figure out why somebody is fatigued, why they aren't sleeping well, why they can't lose weight, etc. And that process of like collaborative and working with somebody, we get longer term sustained results, and we get people who are living better. Like that health span comes into play, because most of us, I think, would agree, if fine, one type of medicine is going to let me live till I'm 99, but I'm going to be, basically immobile and demented and incontinent for the last 15 years of my life. That's choice A. Choice B is, I die when I'm 80, but I'm like, till I die, I'm moving my body. I'm, have really cognitively quite with it. I have all my bodily functions and I feel pretty good. And then I'm done. I know which one I would pick.
Mm-hmm. Right. Well, oftentimes, the functional route, are you saying it's one or the other? Are you saying that you have to live shorter?
No. Hopefully you live to 99 and you're kicking it the whole way. But right. If I had to choose, I would choose short. I would live a shorter life, but a better one.
Yeah, heard. Same. Okay, so you said something that's interesting that is kind of a buzzword. You said like normal range. Yeah. And you referenced that in relation to insurance. Can you give an example of what you mean by like this normal insurance range and kind of why that's significant?
Yep. So we talk about that a lot. We talk about normal versus optimal on the lab values. So when I have a new patient come into the office, and for our listeners and viewers who might not be aware of this, we offer a very comprehensive lab panel right off the bat. And it includes everything from hormones to micronutrient, meaning like vitamin and minerals, to your liver enzymes, kidney health, your blood sugar. It's very comprehensive. And my line at the beginning is that for some of these tests, I'm going to be going for optimal targets. And that might not line up with what the lab has listed as its normal reference range. Now, a lab's normal reference range is simply based on statistics, on the statistical norm for a certain population. And so for some of the tests, if I'm trying to get you to optimal health for you, my target may not line up with that lab's normal reference range. I want you to have optimal health, not like average. Mm-hmm. And so the one that like you and I spoke a lot about on the last podcast, which was on thyroid health, was about TSH, which is thyroid stimulating hormone. And this one is pretty much the main, in conventional medicine, it's the main test that's used to monitor somebody's thyroid health. Mm-hmm. The lab's normal reference range is 0.5 to 5. So anything in that, your thyroid is fine, is considered fine. Now, we also do a full thyroid panel with additional markers on there, but just for that one test. In functional medicine, we have a more narrow window of optimal, and that's usually somewhere around 0.75 to 2. So it's narrower on both sides. So somebody might not technically have hypo or hyperthyroidism, like overactive or underactive thyroid, if they're, say, at a 4. We would consider that borderline, right? And usually that person's going to come in and they're going to be fatigued and they're going to be losing their hair and they're going to have a lot of the symptoms. And so that's kind of a very common difference, is that somebody went to their doctor, they've been exhausted, they had that TSH run, and they were literally like a 4.98, and the doctor, it wasn't flagged as high. And so the doctor was like, you're fine. And to me, it's really obvious that that person is not fine, and that the thyroid probably is playing a pretty big role.
Yeah. What are other examples? That was a really good example. What are some other common examples you see of like the normal range not being normal?
Another one I would say is vitamin D. That one comes up a lot. So this is a little bit of a split, I would say, from conventional medicine to in functional medicine. Our lab, the reference range for vitamin D is, I think it's 25 to 80. Is anywhere within that is considered normal. And so same thing, if somebody has convinced their doctor to even test vitamin D, maybe they had that done and they were at like 26. Doctor said, you're fine. You don't need to supplement with vitamin D. You're good. You're good. In functional medicine, we say optimal is, I usually say 60 to 80. I know some providers even have it a little bit higher, more like 80 to 100. And again, there is the risk, because vitamin D is a fat soluble vitamin, there is a risk of toxicity, meaning it kind of gets stored in the fat tissue. And people can have, reactions when it's really high, like kind of muscle issues and fatigue and cognitive changes. We don't see that happening until you're like well over 150.
Oh, wow.
But conventional medicine gets anxious if you're over 40 or 50. They will tell you to stop supplementing usually.
Oh, really?
And so that's just a difference of opinion. It's not a right or wrong. It's a different interpretation of the research. We like to see optimal levels because we see people's mood, immune health, calcium absorption. Those are just a few examples of what we see with optimal vitamin D levels on the blood work. I have so many people whose energy goes up just by getting that vitamin D level up. So that's a dip. People will be like, oh, I had my D tested. It was normal. And I'm like, well, let me see. Let me see what the actual number is.
Yeah, it's funny. What percent of people in Maine have less optimal vitamin D?
90, 95.
Wow. What about thyroid?
I don't think that's a regional thing, but how many people have an imbalanced thyroid? Oh boy. I mean, I don't know. I can only tell you the people that come into my office. And I don't remember if we talked about this last week, but I would say, I feel like close to 50%.
Oh, really? Wow.
That might be my patient. I think I said this might be my patient population, that I see a lot of perimenopausal and menopausal women, and thyroid disease affects women more than men. And definitely, once you're over 40,
Gotcha.
You have a higher likelihood.
Yeah. Okay. So I'm going to go a little off the notes here. We're going to play kind of like a fun game.
Okay.
I think this will really help viewers, whether you're watching this live with us, which we appreciate you joining. Make sure you drop some comments so we can answer them live. Or you're watching the recording here, is go through like different systems in the body and how functional medicine handles them versus conventional medicine. So the first one is gut health. Like how does insurance-based medicine handle gut health, and like what things is insurance-based medicine good for when it comes to your gut, and then the vice versa, functional medicine.
Okay. So usually if somebody's having some digestive distress of some sort, they start with their primary care doctor. Usually what I'm hearing is take Miralax, which is a laxative. Maybe they'll say take Metamucil, which is a fiber supplement. And then, this is hopefully they will maybe say go see a nutritionist. That's always that's not a bad recommendation. Person doesn't get any better, comes back, and they say, okay, well, we'll send you to gastroenterology. And that's not a bad thing either. I'm a fan of, if the person needs an endoscopy or colonoscopy, great, that's good information. And that's kind of usually the extent of it. Maybe they are given a proton pump inhibitor if it's an upper GI issue. Again, maybe it depends on what, say nothing is found on the colonoscopy, then maybe they're again told to go on Miralax. It really depends on what the concern is, but that's pretty much kind of usually where it kind of ends. Again, if they find something on the colonoscopy, if it's more serious like inflammatory bowel disease, then there will be other medications and other things recommended. But if we're talking about just kind of general constipation, bloating, that kind of thing, so that's kind of it usually. And I'm making these are generalizations. And then within functional medicine, I've been specializing in gut health for a long time. And so I will take probably 10 to 15 minutes just asking questions about the gut. And so I go top to bottom and I'm asking about, heartburn, nausea, gas, bloating, bowel movement regularity, bowel movement consistency, hemorrhoids, all of that. And then lots about what they're eating, what they're not eating. Have they ever had a colonoscopy, et cetera? And getting a lot of health history with that. If they've had any previous GI diagnoses, if they've taken when they did take the Miralax, what happened? Did they do better or worse? Did nothing change, et cetera? History of antibiotics, on and on and on. And then we have some really great comprehensive stool panels available to us, which give us a whole readout in terms of what's the microbiome. Is there a parasitic infection? Is there a bacterial infection? I've had a couple of these come back in the last week with candida overgrowth, inflammation, gut inflammatory markers, not systemic inflammatory markers, but specific to the gut. There's just a lot of information that's available on these tests. And this is, again, unfortunately, not usually covered by somebody's insurance. And so there's another kind of, this tool is available to me, but not within conventional medicine because it's not, reimbursable. But it provides so much information and it really helps us guide the treatment. Do we need to treat a gut bacterial infection, a fungal infection? Do we need to do we need to build up their microbiome? Do we need to specifically target inflammation? Is it a dietary piece? Again, we've got so many tools. I will use antifungals. I will use antibiotics, when necessary, and then a lot of stuff to help kind of restore the gut afterwards.
Okay, gotcha. Let's do the next one. So insurance-based medicine, so conventional medicine versus functional medicine for weight loss and low energy.
Insurance versus functional medicine we're combining weight loss and low energy here.
Yeah. From what I understand, most patients come in with both.
They often do. Yeah. Again, I would say probably 90% of our patients have low energy and maybe 85% are trying to lose weight. So yes, you are correct. So, I don't know, conventional medicine, maybe lip service, eat better and exercise with no more guidance, right? Again, 5-minute visit. What are they going to say? Maybe a referral to a nutritionist. Maybe a prescription for something like phentermine, which is a weight loss medication. Depending on the provider and the person's actual weight, maybe they would be put on a GLP-1 agonist medication. And then fatigue is tough. Hopefully they would do some testing. They would at least look at iron and ferritin levels, thyroid health, ruling out anemia, ruling out hypothyroidism for fatigue. Maybe given an antidepressant. It's just a very limited toolbox, I would say, both in terms of testing and in terms of treatments. They just don't, it takes time to talk to somebody to figure out why they're not losing weight and why they're tired. And if you have 5 minutes, you just simply cannot do that. With weight loss, I will often refer to a health coach, to a nutritionist. I will spend the time to figure out, what the person is eating. Just what their relationship is with food. What I eat healthy really means a lot of different things. And what their caloric output is, right? So I exercise means a lot of different things. What does that mean for that person? And what might be more appropriate for that person? And we do a lot with hormonal balancing. And so there's a lot of people who really are kind of doing their best and doing all the right things in terms of eating well and exercising pretty well. And they happen to be a 50-year-old woman and they're gaining weight. And that's often a hormonal component. So hormone optimization as well as lifestyle. And then we will use medications, right? We will use GLP-1s, at varying doses, kind of specified, personalized for that person if it makes sense. But it's always part of a bigger picture. We will use peptides when it's appropriate. But I really try to stay away from transactional medicine where somebody has a complaint and I hand them a medication and I say, I'll see you in 6 months. To me, that's not great care. That's not changing the paradigm. So, even if on the outside, some of the medications might look the same, like the level of support, the level of investigation of root cause medicine, that's completely different. Maybe there is another metabolic imbalance that needs to be looked at, and we'll do the tests. We'll figure it out.
Yeah, great. Okay. Let's do insurance, conventional medicine versus functional medicine for hormone replacement therapy.
This is a fun one.
Yeah.
All right. Conventional versus functional medicine in terms of hormonal care, hormonal imbalance. So depending on what's going on, right? So, is this a male? Is this a female? Is this a 24-year-old woman or a 54-year-old woman? It's all going to be different. But I think in conventional medicine, we will, maybe it'll be primary care. Maybe they will refer the woman to a gynecologist, depending on what's going on. Often it's going to be oral birth control, which can be effective for various conditions. If there's a mood component, like a premenstrual syndrome, premenstrual dysphoric disorder, they may also be put on an antidepressant, and maybe referred to a therapist. And those aren't necessarily bad ideas. And then what else? For that's for a younger woman usually. An older woman, they might too. Maybe it might be the same. It might be a birth control pill. It might be an antidepressant. But oftentimes, if it's a perimenopausal woman or a postmenopausal woman, the woman might ask to have her hormone levels checked, and she's refused. Mm-hmm. Or if they do run it, they'll be like, everything's normal, you're fine. And again, unfortunately, the patient feels dismissed. Maybe she's put on an antidepressant. Maybe she's told to just have a glass of wine. Maybe she's told this is just aging.
Wait, that's something you've heard before?
Oh, yeah.
Really?
Yep. Just relax. Just have a glass of wine.
Really?
Yeah.
Wow. Okay.
Yeah.
Interesting.
And Yeah. And likewise, and again, I feel like you've heard me say this a lot, but unless a woman is postmenopausal and having hot flashes, she will, and even if she asks for some kind of hormone replacement therapy, she's told she's fine, she doesn't need it. Mm-hmm. And I am really a huge proponent of looking at somebody while they're perimenopausal, not just postmenopausal, and looking at the whole picture. And that's just not going to happen usually in conventional medicine. It's just not part of the typical training. So when in functional medicine, we're looking, it's very personalized. How old is this person? Is it a male? Is it a female? How much is low testosterone playing a role in this man's fatigue, or his, low libido, low drive, all of that? How much of this younger woman's anxiety and depression might actually be hormonal? It's different for every person. And that's why we have the wisdom, the training, and the time to help figure that out. So is there additional testing that needs to happen? Yes, this person's labs might look normal, but maybe they're not optimal for that person. And so combining that with whatever the health history is telling us, with what the symptoms look like, can start to give us an idea of, estrogen is too high, progesterone is too low, testosterone is too low. What's potentially playing a role, and looking at, potentially changing nutrition to help alter that, maybe using some botanicals to help balance that. And then when appropriate, hormone replacement therapy in safe, low doses to help balance that out. But again, always comprehensive, always personalized.
Mm-hmm. Gotcha. So we have a little comment here we kind of touched on, but we'll retouch on it because this person was kind enough to ask it. So can you give me guidance on iron and ferritin levels? So iron and ferritin and just other vitamins versus conventional medicine versus kind of functional medicine.
Sure. So the question is, can you give me some guidance on iron and ferritin levels, and what would you, meaning MedMatrix, offer versus standard or allopathic medicine? So this is on our initial panel, and I'm like, every day I'm ordering kind of follow-up iron. We call it an anemia panel. So looking at iron and ferritin, like once we've kind of started certain treatments, trying to monitor those levels. And unfortunately, people are often low in both iron and ferritin. So iron, I don't put as much weight on iron because iron levels are going to fluctuate a little bit more day to day, whereas ferritin is your warehouse or your storage of iron, done primarily by the liver. And you can have, again, quote, normal iron levels, but if your ferritin is at, I have people coming in with a ferritin of 7, and then I have people coming in with a ferritin of 11, and both of those are very low. For me, optimal, and in functional medicine, we usually say optimal, this is for a woman, is between like 50 and 100. And a lot of women are well below 50. And guess what? They're tired. Sometimes, it's a woman who's still menstruating. Sometimes there's, blood, it's obvious blood loss, not always. But obviously, we can't give specific medical advice, but I guess I would say this is a perfect example. You ask a great question. It's a perfect example of more comprehensive testing, and just having the ability, like once we do start, a non-constipating iron supplement, and once we do start talking about diet and ways to get iron increased in the diet, I will then retest in 3 months, and we can check that and find out if your energy is better. Mm-hmm. And we have the ability to do all that.
Mm-hmm. Yeah. Okay. That's a great example. Good question, Jeannie. Hope that helped. All right. Let's do one more. I'll let you pick this one. What do you think is another good comparison for conventional versus functional medicine?
Well, did we exhaust the thyroid one last week? That was a good one.
Oh, what about joint pain? So,
Okay, joint pain's a good one.
Yeah.
So how does conventional medicine versus functional medicine approach joint pain differently? Well, joint pain, of course, could mean anything. It could mean osteoarthritis, rheumatoid arthritis. It could be a different connective tissue autoimmune disease. It could be a tick-borne illness. It could be just simply inflammation, or the person is really overweight. There's a lot of different, and it doesn't have to be just one of those. Somebody could have multiple causes for joint pain. Again, in conventional medicine, I think, unfortunately, if somebody is overweight, the questioning stops there. They're basically like, you just need to lose weight and then your joints will improve. And you know what? They're probably partly right, but they are not taking the time to make sure that there's not a tick-borne illness, an autoimmune condition also contributing, right? Because we are complex beings, we have complicated bodies, and we don't always just have one thing going on. So, and hopefully in conventional medicine, if like an x-ray is warranted, they'll do that, they'll do the thing, and then maybe send them to physical therapy, which is also a good idea. And in functional medicine, we will do all of that. But again, we will do that testing to make sure that there's what is contributing. Is it simply this person just needs to lose weight? Not just needs to lose weight. That's, easier said than done. Or is there a different type of inflammatory condition contributing to the joint pain? I know I'm always talking about hormones, but when the estrogen level drops in those postmenopausal years, that's often when joint pain gets worse. And it's because of the lack of estrogen. Even with testosterone, even in men, when testosterone is too low, is suboptimal, that will often, men will often have joint pain. And when we kind of optimize that will often improve. So it's like a different, I feel like it's being more open-minded. It's a bigger toolbox. It's really looking at this individual. Like, is it simply that they are eating a diet that is so inflammatory and that's the only way they know how to eat, and they've been eating that way for 45 years? And that's, we don't do anything. We don't add any supplements. Don't do any medications. We really work on re-educating them about what to eat.
Okay, that's a great example. Oh, nice. We got some comments coming in here. Is leaky gut a problem among your patients? Sorry. I guess, how often are you treating people with leaky gut?
Yes, I would say leaky gut is a common problem among my patients. We do have tests for this. We have, again, that comprehensive stool test that I mentioned. That includes something called zonulin, which is one marker that we can, kind of use to see the degree of leaky gut syndrome. And I'll explain leaky gut in half a second. There's other tests, advanced tests that we can do to look at it. And sometimes just talking to people, I might kind of presume that they have leaky gut. So really quickly, leaky gut syndrome, it's not an official ICD diagnosis. It's up until this point, it's still considered a theory, but pretty widely accepted within integrative and functional medicine. So the idea is that there's a certain level of gut permeability. So in the small intestine primarily, there are these cells that line up next to each other, and they need to be permeable enough to let nutrients in from the gut into the bloodstream, but they need to be tight enough, cell to cell, to keep large and foreign particles from passing into the bloodstream. If there's a certain level of inflammation, if somebody has a diet really high in sugar, in, again, inflammatory foods, if there's been history of antibiotics, some other medications, sometimes like chronic proton pump inhibitor use, PPIs, then you're going to get these cells kind of separating, and you're going to get increased permeability. That triggers the immune system to set off an inflammatory cascade. And that inflammation can show up anywhere in the body. It might show up in the brain. It might show up in the joints. It might show up in the skin. But the idea is that it kind of flushes out that phrase that like your health starts, anything with your health starts in the gut. And that's kind of what that's referring to. And so unfortunately, the standard American diet is pretty inflammatory. Unfortunately, a lot of people have been on a lot of antibiotics as children and or adults. And there's this, a lot of people are on Prilosec and Pepcid for years and years and years. So yes, in answer to your question, I do think leaky gut is a common problem.
And when you have leaky gut, is it just like kind of lost hope, or like what are some strategies that you use?
Not at all. So obviously, if there's a dietary, lowering inflammation overall, whether that's through food, through nutraceuticals, I have pretty successful protocols for getting people off of these proton pump inhibitors unless they absolutely need to be on it. Camera went out. What should I do?
Tech person is on vacation right now, guys. So Dr. Rose is going to replace the camera. While she does that, we'll do a little shout out to Med Matrix that makes this podcast possible. So if you do live in Maine, New Hampshire, and you're kind of looking to, take more control of your health and do some of this more advanced testing, work with providers like Dr. Rose, who can spend more time with you, really understand your lab work, and really create a personalized plan, you can go to medmatrixusa.com. And then when you talk to a patient coordinator, just say you came from one of our webinars. We really appreciate it when patients take the time to educate themselves, because patients who are playing an active role in their health are more successful in their health. So, all right, back to it. So you were talking about leaky gut protocols and success rates, things like that.
Yeah. So overall lowering inflammation, right? And then there's specific ways to kind of get people off of those medications that may be contributing to the leaky gut. And then there's some really great, there's some great peptides. There's some great botanical and nutraceutical products that I've, again, had a lot of success with to heal leaky gut. It doesn't happen overnight, but it definitely, people will start to feel better, and they can do it without, and then they can be off of some of these medications as well.
Great. Okay. So you mentioned something like just now, you said like people be on medications that will cause leaky gut, right? And we hear often like a lot of conventional medicine is kind of a Band-Aid solution where they cover up symptoms and they don't really find the root cause. We are talking about insurance on this episode. So how does insurance play a role in that, where it's like you kind of do end up with these, you see a lot of patients. I know a lot of patients come to practice where they had one issue, they went on one medication, went on another, and then they're kind of worse off than when they started. So how does insurance play a role in that, kind of like covering up of symptoms?
So I think, people being on one medication and then another one, and then the question of the role of insurance in those, I guess, chronic and kind of domino effective prescriptions. I think there's a lot of aspects to it. It's, as you mentioned, like a lot of people coming to see us. That's the care that they've received up until this point. And it's really, the insurance-based model is largely symptom management, and it's not root cause based. And so somebody has some heartburn, they're put on famotidine or omeprazole. If you look, those medications are really supposed to be for 14 days, but they're put on it and they're just never taken off. And nobody's ever talked to them about what they might be eating that might be contributing, or the fact that they're, having a pretty hefty snack at 10 o'clock at night and then going to sleep. Like nobody's, that's kind of a very quick example of just looking a little bit deeper. Somebody's on, I'm trying to think of some other examples, but there's so many where you just kind of, you have one lab result and you're given a medication, or you have one symptom and you're given a different medication, and then by the time they come in and this person's 65 years old, the list of meds is just, and they've just been on it. Nobody's taken the time to see if we can actually start to if anything, just lower the doses at least, and then hopefully even just kind of whittle that whole list down, because it takes individualized care, and that doesn't fit into the model. There really isn't. You have to work on lifestyle, education, nutrition. You have to look at other ways to kind of optimize somebody's metabolism so that they no longer need the statins, and they don't need the antihypertensives, and they don't need all these other things, because they've done the work. Or maybe they do need them, but at much lower doses. And so it's hard, because that's, more often than not, this is the only model that people know, and the only option that's been offered. And they might be in their 40s, 50s, 60s, 70s before they even realize that they don't want, we call it polypharmacy. They don't want that list anymore of meds.
Mm-hmm. Can you explain that? Polypharmacy?
Polypharmacy just means like many drugs. Like you're just on a long list.
Gotcha. I've never heard that before.
Yeah.
Okay. We're through all the questions here, so we're just going to go right into Q&A, and then we'll do a patient case study, and then that'll be it. So question here, and then guys, for those of you who are live, feel free to drop some more questions. Can you explain mitochondrial health testing and treatment? And then if you can kind of tie that back to insurance, just to stay on topic, that'd be
great. Sure. So mitochondrial health testing and treatment. So we now a mitochondria is what's called an organelle. It's a part of every cell in the body, and it's sometimes thought of as like the engine of the cell. It's really where all the energy metabolism pathways happen. And so for energy to be produced, you need certain nutrients, certain vitamins, certain minerals. And then you even need kind of certain enzymes, which there's some very common genetic mutations that impact mitochondrial health. And so even if you're getting the right nutrients, if you have these certain genetic mutations, your mitochondrial health, your energy pathways might be compromised. And so we have tests, both genetic tests and other kind of nutrient, testing nutrient levels to kind of figure out what somebody's mitochondrial health actually looks like. No surprise here, these tests are not reimbursable. They are not covered by insurance. Treatment is hopefully based on some of these test results. So you may have heard of like the most common the test for this is called an MTHFR test, and that's looking at a methylation. If you have an enzymatic mutation in terms of, or variant in how you are kind of handling, largely it's like the B vitamins and how well those B vitamins are being processed. If they're not processed optimally, you're going to have a higher tendency for inflammation. You may have a higher risk of things like fatigue, depression, anxiety. And this is genetic. This is maybe something that you've been dealing with most of your life without knowing why you had these tendencies. So if we have that information, that can help us figure out what nutrients make sense for you, what diet makes the most sense for you. And a lot of people are like, well, I just figured out that I have this mutation. I'm going to get my kids tested also. Or, my father's been dealing with depression his whole life. If I can convince him to get a test, that might help him figure this out. So good information, not part of the conventional insurance-based model, unfortunately.
Okay, great. Karen, I hope that helped. All right, so why don't we always like to do a case study for those of you who are joining us for the first time. So why don't you do a case study? So probably have a patient who went to insurance, kind of wasn't getting help, and then came to MedMatrix, which is probably most of the patients.
I'm like, which one to pick from? Right.
Yeah, I'll let you pick whatever patient you want. Go through a case study.
Okay. So this is a man. He is, I think he's 50. Maybe he might be 49 or 50. And so he came to us probably around 9 or 10 months ago, and he had all the standard meds. So he was on a statin medication. He was on 2 blood pressure medications. He was overweight. He was on a medication for heartburn. He had a previous diagnosis, I think already of non-alcoholic fatty liver disease, and low energy, and not feeling great, and had tried with his primary, it was a series of primary care doctors over the years who had basically, he didn't have a long relationship with any of them, and they would see him and they'd see his cholesterol was still high, and so they'd keep him on the statins. His blood pressure was so high, they'd add another medication for that. And he wasn't, this started when he was like 40, and this had been his life for 10 years. He was just kind of on these medications. And so he came to us just feeling kind of like, I really don't feel good. I haven't felt good for a while. And I don't really, like, it was just understandably like overwhelming for him, right? He's like, I don't know what to do. And I'm just given more meds and nobody seems to have an answer for me. And so his lab work did not look great on that initial panel, despite being on some of these meds. And nobody had ever talked to him about what he was eating. And he was kind of an example of like, he's like, well, I sometimes I'll go for a walk. Like, that was the extent of movement. He's like a workaholic, lives alone, mostly does takeout. And so a lot of it was kind of educational, it wasn't like the sexiest treatment plan right off the bat. It was really like, let's do some baby steps in cutting back on the takeout and like learning how to cook some real food, and boosting the vitamin D, boosting the vitamin B12, just some real kind of basic things. And I don't think we even did anything bigger than that initially, but he already, even with those, I'm going to call them simple, but these are not, the lifestyle things are not easy. He's the one doing the work, but after that, he had made enough of a difference that I did see some improvement on the blood work. And then we were able to I think we did do some hormone optimization with him. He did start to get a little bit more energy, which helped him go to the gym, right? And then going to the gym, he was like motivated, and he started to actually want to work out and have the energy to work out. His mood improved. So it was kind of a little bit of a positive domino effect in that regard. And he is now on a very low dose. We call it a microdose of a GLP-1 medication, which has really helped his metabolism. He's down to 1 blood pressure medication. He's off of the proton pump inhibitor, and he's cut his statin. He's still on the statin, but he's on a lower dose. Mm-hmm. And he doesn't feel 100% right now, but he feels probably like, 85% better. And every time I talk to him, it's better than the last time.
Mm-hmm. Yeah, it's a big improvement.
Yeah.
To your health, right? Yeah. Awesome. Cool. All right. Well, that's it for today. Dr. Rose, do you have anything to add?
No, I hope that some questions were answered. I know people ask, it's a conversation I have frequently with people of kind of, why are you, insurance, like why can't this be covered by my insurance, that kind of thing. Or, I think almost everybody who comes in here has felt dismissed, has a certain level of frustration with the current system. And for the most part, it's really not individual providers. I think most providers go into this because they want to help people. But it's just, they kind of end up having their hands tied behind their backs. Mm-hmm. And so just so that people know that it's like, we hear you and we know how frustrating it is. And I think the more people that know that there are other options and that there is this different approach, and that every day we just see people feeling better, and that's really rewarding.
Fantastic.
Yeah.
Cool. Thank you, Dr. Rose.
Thank
All
you.
right. And then if you're watching live or watching recording and you want to actually get some medical advice and kind of come up with a personalized plan for you, you can go to medmatrixusa.com and apply to be a patient. All right, everyone. Thank you so much for joining, and we'll see you in the next one. Bye, guys.
Thank you.